And thanks for Mathis for giving me the opportunity to talk about preservation of bone stock. And my talk is following the talk of Carl. And these are my disclosures. And as we all know and heard now, that loosening is one of the top reasons for revision in nearly all registers you can find over the world. And something that looks like this. This is a patient with a normal function. He has no pain, is very satisfied with his hip. But something like this you can find in a lot of those modular stiff cups. You see a decrease of the bone around the cup, and not only around the cup, you can also see it in the part of the proximal femur. And something like this that looks quite harmless on the X-ray, if you look at this, can turn out to be really demanding in the operation theater. Because, to be honest, I wouldn't assume big osteolysis like I found in the CT scan when I just look at the X-ray. And this is the same patient, and X-ray and CT scan were performed on the same day. So if you have to revise this cup with such a big osteolysis, we all know that we face quite a demanding situation in the operation theater. So, but when we think about what we do when we implant a cementless metal back cup in a patient, we put really a stiff piece of metal into a relatively soft tissue that we call bone. So, okay, when we have the bone, we don't think that it's soft, but when we compare the elastic modulus of bone and the metal back cup, we see that the metal back cup with more than 100,000 newtons per square millimeter is a lot stiffer than the bone. So this is a very recent paper published by Young in BJJ, and he described the way of load transmission. He compared cemented cups with uncemented cups. And we know that the load transmission in a cemented cup goes more medially, and the load transmission of an uncemented cup goes more via the equator. And we found good arguments for cementing a cup, and we found arguments for staying cementless with a cup. But this talk is not about cementing or not cementing. This talk is about the RM cup, which is, in my opinion, a very good way, which we see later, to sort of have both ways of load transmission in one cup. Because if you look here at the elastic modulus, we see that this is the elastic modulus of this isoelastic cup, how we call it, is much more similar to bone than a metal back cup. So we ask ourselves how it works out after years in the midterm follow-up when we compare such a isoelastic cup with very stiff metal back cup. So we designed a prospective randomized controlled trial. All patients had a primary osteoarthritis, and we allocated 25 patients with the RM cup and 25 with a ELO-fit cup. And both cups, I have to say, are very good cups in the registers. So no difference in the outcome, more or less. All patients were operated on in a supine decubitus through a lateral approach, which you can still find very widely distributed in Germany. We used the Optimus short stem with a 32 millimeter L minor head in all patients to avoid bias. The mobilization followed our standard protocol with full weight bearing from the first day on. And we conducted DEXA measurements post-operatively as a baseline and 4 years after surgery. And we defined our zones around the cup, defined by Roth. You all know the Dili and Charney zones, and Roth divided the zone number 2 in 2 subzones. He published it 10 years ago from our clinic, so we used it because we had experience with it. Zones, and of course the well-known femoral zones by Grün. And these are the results. We didn't find differences in the equator zones 1 and 4, but we found a significant difference in zone number 2. And if we look at the modular cup, we had a decrease of the BMD in that zone number 2 of around 16%. In the RM group, we had a decrease of only around 5%, which meant a significant difference in both. But the explanation for us then was that through this more isoelastic design, we found a load transmission, which is not only via the outer rim, via the equator, like in a normal metal back cup, but also via the more medial part of the acetabulum. We found a second result, which was very surprising for us. We didn't look at that. We didn't search for this specifically, but of course we we looked at the green zones too, and we found there in green zone number 1 also a significant result. When a stiff metalback cup was used, we had more decrease, around 16% of BMD, compared to around 7% when an isoelastic cup was used. Still, we don't have an explanation for that, but at least it's an interesting result. And as I know, different study groups are working on several ideas like that to see if it's maybe an overall elasticity of the whole cup that makes a difference, or what could be the explanation for that, what we found here. So this is the region number 1. When we talk about the clinical use, just shortly, when do I personally use this cup? We use it as, this is my number 1 cup. I use it in every kind of patient, like the primary osteoarthritis. But like we heard before, I use it especially in patients with very poor bone quality, and I chose that X-ray because I can prove the poor bone quality, because you can see here on the right side the patient suffered from a fracture. Intraoperatively, she was taking, because of a rheumatoid arthritis, corticosteroids for more than 25 years, and even though the bone looked quite good on the X-ray, it was really poor in the operation theater. So a cementless stem didn't work out on the right side. So the consequence was to cement a stem on when she came after 1 year for the second side. But what I wanted to say is that the cup, which is really more elastic to implant, worked out in this very, very osteoporotic patient quite well, and I did not see any necessary to, for example, cement the cup on the left side. We use it in very weak bone too. This is a patient with a femoral head necrosis, and you all know those cases. This is a very good indication for me to use the RM cup. You can screw it in. I never did it. Oh no, it's not correct. We talked about this yesterday. I used it just once because I was curious how it works with the screws. It was 7 years or 8 years ago. These are X-rays from Dr. Joe Banks from Scotland. Thank you very much for that, Joe. And I just wanted to show here the possibility of screwing in such a cup, because still a lot of surgeons don't know that we have such an option in this isoelastic cup. And Joe does more crazy things. He even uses the iron cup in revision cases. I never did it, to be honest, by myself. So thanks again, Joe, for providing me those X-rays. But what we can see here is this is on the left side, day 1 after surgery, and you see quite a good bone remodeling on the 10-year follow-up X-ray. The clinical outcome, like we heard before in the registers, is very good, but we also can find single studies with long-term results. I can see Dr. May from Kassel here, and 2008. I'm waiting for the 2018 results now, 30 years. It's a 20-year follow-up of the RM Classic Cup with 94% of aseptic loosening. It's an endpoint which is a brilliant results, and we can see good midterm results of this cup. So in my opinion, this cup can be used very widely for nearly any kind of patients. So I'm coming to summarize now. Loosening is the top reason for revision. The elastic modulus of the RM press fit cup is more similar to that of bone compared to a metalback cup. In our 4-year follow-up, we provided here more periacetabular bone was preserved in the polar region when this isoelastic cup was used. And interestingly and surprisingly, more bone in the region of the parietal trough was preserved. I don't know why. And my indications personally is the primary, but as you can see, some brave guys use it in revision arthroplasty too. So merci beaucoup, and thank you very much for your attention.